Hello there, my valued and highly esteemed and treasured viewers and listeners, and welcome back to our Pharmacotherapy MCQ series, to part 22 to be specific. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, our premier virtual clinical pharmacy institute with a difference for capacity building for the healthcare sector. We are the virtual clinical pharmacy institute where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your precious time as I impart a few tips that will enable you be more effective in your line of duty. Welcome back. So question 1 reads, which of the following rivaroxaban doses does not have to be taken with food? Is it the 10 milligram, the 15 milligram, the 20 milligram dose, or must all doses be taken with food? I'll give you 10 seconds to choose the correct answer. So 10 milligrams it is. The absolute bioavailability of rivaroxaban tends to be dose dependent according to literature out there. Now, when the 10 milligram dose is administered, it's estimated to be 80 to 100%, and it isn't affected by food and can therefore be taken with or without food. Now, for the 20 milligram tablets, in a fasted state, the absolute bioavailability according to literature is around 66%, much lower than the 10 milligrams. Its co-administration with food increases this bioavailability. Therefore, it's recommended that for the 15 and the 20 milligram tablets, we need to take them with food for better absorption, just to increase the bioavailability so that our patients don't end up with coagulation. Just by the way. So let's move to the next question, which reads, which of the following vasopressors has the longest half-life, thereby giving it the longest duration of vasoconstrictive activity? Is it dopamine, norepinephrine, epinephrine, or vasopressin? I'll give you 10 seconds to choose the correct answer. Vasopressin it is. Now, vasopressin has the longest half-life among those four, and this helps avoid redosing, but it could be bad if the adverse drug reactions occur, or if prolonged periods of increase in afterload are too difficult for the patient, especially with a failing heart. So there is a caveat, there is a catch. The half-lives of those vasopressors are as follows, just for your information. Vasopressin is 10 to 15 minutes. Epinephrine is below 1 to 5 minutes. Dopamine is around 2 minutes, and norepinephrine is slightly below a minute. Our next question is, which of the following vasopressors is the drug of choice in acute anaphylaxis that is causing both dyspnea and hypotension? Is it norepi? Is it epinephrine? Is it vasopressin or dopamine? I'll give you 10 seconds to choose the correct answer. So So epinephrine it is. Epinephrine is a vasoconstrictor that is thought to have equal stimulatory activity on the alpha 1, beta 1 and beta 2 receptors, unlike the others. And this is helpful in the situation of anaphylaxis because the beta 2 agonist activity helps correct some of the bronchoconstriction that you experience in anaphylaxis, which tends to cause the shortness of breath. So it would in this case help dilating the bronchi and relieve the dyspnea or the bronchoconstriction. Now the stimulation of the alpha 1 receptor causes vasoconstriction, thereby helping with improving hypotension that occurs in this particular situation. Now, just for your information, phenylephrine is a vasopressor with purely alpha 1 agonist activity and with no beta 2 activity. Norepinephrine, on the other hand, is generally considered to be a vasopressor which primarily stimulates the alpha 1 receptor to increase the afterload or systemic vascular resistance, what we abbreviate as SVR, due to its vasoconstrictive properties on the arterial vasculature. It can also stimulate the beta 1 receptor, leading to a slight increase in the pulse rate. Now, vasopressin, on the other hand, is a vasopressor that is known to stimulate the V1 receptor. And that leads to vasoconstriction, and it has absolutely no effect on alpha 1 or beta 2 receptors. It does not produce alpha 1 or beta 2 effects, just for your information. Let's move to the next question. JPG is a 66-year-old woman with a diagnosis of AFib. She also has chronic kidney disease and her creatinine clearance stands at 30, fairly low. Which of the statements below is true regarding the use of an antiarrhythmic drugs in JPG's treatment? Is it dronedarone would be more likely to cause pulmonary or thyroid toxicity than amiodarone in her case? Or is it true that the use of amiodarone is contraindicated for her due to her renal function? Or is it true that sotalol is contraindicated for her due to her renal function? Or finally, is it true that class 1B antiarrhythmic agents such as mexiletine would be the most effective options to maintain sinus rhythm for our patient JPG? I'll give you 10 seconds to choose the correct answer. So in my opinion, sotalol is contraindicated for this particular patient because of her creatinine clearance, which is as low as 30. Now the product insert for sotalol indicates it is contraindicated when the creatinine clearance is less than 40. Patient's creatinine clearance is at 30, if I remember well, so it's contraindicated in our case. Now dronedarone is made by removing iodine and adding methane sulfonyl group, and this helps in reducing iodine accumulation in tissue, making it a safer alternative. That makes alternative A wrong. Now class 1B antiarrhythmic agents are used for serious ventricular arrhythmias and for the suppression of PVCs. So that makes alternative D wrong as well, and it qualifies alternative C as the best option in this particular question. Let's move to the next question. which reads, a 69-year-old African-American male patient is diagnosed with stage C heart failure. He has a left ventricular ejection fraction of 25%, fairly low. He's also hypertensive and overweight, obese. The BMI is too high. He denies recent heart failure symptoms and declares, in his own words, he's doing just fine. He's currently taking 20 milligrams of fosinopril once daily. He takes 20 milligrams of furosemide after breakfast, and prophylactically he is on low-dose aspirin, 81 milligrams once a day. Today his BP was initially 130/72 with a heart rate of 82. You opted to repeat the measurements and you've got a higher figures of 138/74 with a heart rate of 84. So my question to you is, based on the information provided above, which of the following recommendations would you consider most appropriate for our patient? Would it be the addition of metoprolol succinate at a dose of 25 milligrams once daily? Would you increase the fosinopril dose from 20 to 40 milligrams once a day? Or would you double the furosemide dose to 20 milligrams twice daily? Or would you continue the current therapy as is? I'll give you 10 seconds to choose the correct option. So I would add metoprolol 25 milligrams once daily to his current regimen. Now, adding a heart failure specific beta blocker such as metoprolol succinate is the most appropriate, because beta blocker therapy is considered one of the foundations of heart failure management. There is mortality benefit, especially given that his heart rate is well above the target of upper 50s to low 60s. If you remember well, his heart rate stands at between 82 and 84. It's too high. We need to bring it down to 50-60 range. And metoprolol succinate is FDA approved for use in heart failure. Now, just like to remind you that the tartrate form is not interchangeable with the succinate form in heart failure management, because the FDA has not approved metoprolol tartrate for use in heart failure. Now, the other beta blockers that have evidence for reducing mortality in heart failure include carvedilol and bisoprolol. Now, bisoprolol has been shown to reduce mortality, but it is not FDA approved for use in heart failure. So I would opt for metoprolol succinate to be specific. Let's move to the next question. TNA is a 59-year-old black female who was seen at the heart failure clinic 3 days ago to initiate therapy for her newly diagnosed left-sided systolic heart failure. Now, she was initiated on a low-dose lisinopril, 5 milligrams once daily to be specific, and 6.25 milligrams of carvedilol twice daily, together with 20 milligrams of furosemide once daily after breakfast. Today, she reports a worsening dyspnea, lower extremity edema, and fatigue. And in her own words, she claims, "I felt a lot better until they started me on these medications." She's angry and mad at you. So which of the medications below is most likely to be the cause of her symptoms that make her feel awful? Is it lisinopril, carvedilol, digoxin, or furosemide? I'll give you 10 seconds to choose the correct answer. So it is carvedilol. Now, when initiating beta blockers, especially carvedilol therapy in a patient with left ventricular systolic dysfunction, such patients may experience symptoms consistent with decompensated heart failure, especially if you start at a very high dose. And this is the main reason that patients are started out on low doses of carvedilol and titrated every 14 days, 2 weeks. Do not rush them, otherwise they'll come complaining like this particular lady. Now, the initial starting dose is usually around 3.125 milligrams orally every 12 hours. And this can be titrated, as I said, every 14 days until you achieve a target of at least either 25 milligrams twice daily or as tolerated. Don't push them too hard. Now, this particular patient was started at a higher dose of 6.25, and this dose only further worsened her symptoms. So that was a lapse on the part of the clinical team managing her. It should have been 3.125 BD, not 6.25 BD. Let's move to the next slide, which reads, which statement below is true regarding the use of antithrombotic therapy to prevent cardioembolic stroke in patients with atrial fibrillation? Is it the use of warfarin is superior to the combined use of aspirin and clopidogrel? Or is it antithrombotic therapy can be discontinued if sinus rhythm is achieved? Or is it the risk of intracranial hemorrhage with warfarin increases once the INR exceeds 6? Or is it warfarin therapy is recommended for 14 days after cardioversion to normal sinus rhythm? I'll give you 10 seconds to choose the correct answer. In my opinion, A is the correct answer. Now, the efficacy of stroke prevention with warfarin in AFib is superior to aspirin and clopidogrel combined. Now, the risk of bleeding with warfarin compared to this combination is the same, so that gives warfarin an upper hand. Now, antithrombotic therapy is recommended in both rate and rhythm control, so that makes answer B wrong. And intracranial hemorrhage with warfarin begins to increase with an INR greater than 3, not 6. So that makes answer C wrong. Then warfarin therapy is recommended for 4 weeks, not 2 weeks like in this case, after cardioversion to normal sinus rhythm. So answer D is wrong as well, in my opinion. Let's move to the next slide. So which of the following statements is the most accurate about aspirin use in patients who recently had NSTEMI and are now being treated for secondary prevention against another cardiovascular event? Is it A, it is an irreversible inhibitor of cyclooxygenase 1? Or is it B, it isn't indicated after 30 days if the patient is taking clopidogrel for a drug-eluting stent after PCI? Or is it is combined with dipyridamole and marketed as Agrenox for the prevention of cardioembolic stroke in patients with AFib? Or is it is relatively safe or non-toxic in the context of an overdose? I'll give you 10 seconds to choose the correct answer. So A is the correct option. Aspirin happens to be a COX-1 inhibitor. Now it differs from the NSAIDs in that it irreversibly inhibits COX-1, whereas NSAIDs competitively inhibit COX-1 and COX-2. That's just a by the way. Now in patients with drug-eluting stents in place after PCI, both aspirin and clopidogrel must be used for at least 12 months, not 30 days, 12 months after stent placement. So answer B is wrong. Now Agrenox is a combination product that contains aspirin and dipyridamole and is indicated for secondary prevention against ischemic, not cardioembolic, ischemic stroke. So answer C is wrong as well. And aspirin doesn't have a good safety profile in the context of an overdose. It is associated with a mixed acid-base disorder where patients most commonly initially develop a respiratory alkalosis, which is then followed by a metabolic acidosis, thereby creating what we call a mixed acid-base pattern. Now, most of such patients end up having to go through dialysis, and some may require ICU admission. Yeah, so it is fairly toxic. I disagree with answer D. Let's move to the next slide, which reads, how does Lexiscan decrease coronary blood flow when used in cardiac stress test for risk stratification purposes? Is it by A2A adenosine receptor agonism? Is it by adenosine deaminase inhibition? Is it by beta-1 adrenergic receptor stimulation? Or is it by provision of exogenous adenosine? I'll give you 10 seconds to choose the correct answer. So A is the correct answer. It happens to be an A2A adenosine receptor agonist, which is cardiac specific and reduces adverse effects compared to other vasodilators and stimulators used in stress testing. It has an upper hand over them. Now, Pasantin inhibits adenosine deaminase, reducing the breakdown of endogenous adenosine, not this particular drug Lexiscan. And then Dopamine is the one that stimulates beta-1 adrenergic receptors, not Lexiscan. Then adenosine administration provides the exogenous adenosine, and that only lasts a short duration. It's quickly broken down. That's just for your information. Let's move to the next question, which reads, which of the agents listed below is a classic class 1C antiarrhythmic agent used in the management of various atrial and ventricular dysrhythmias? Is it amiodarone, flecainide, sotalol, or verapamil? I'll give you 10 seconds to choose the correct answer. So flecainide it is, and flecainide is the only class 1C antiarrhythmic agent on that list. Other class 1C agents may include propafenone, for example, and flecainide should be avoided in patients known to have structural heart disease. Now, amiodarone and nexterone, together with sotalol, belong to class 3 of the antiarrhythmic agents. So that makes options C and A wrong. And then verapamil, which is D, belongs to class 4. So it's wrong as well. It does not belong to class 1C either. That's just for your information. Let's move to the next slide. A 66-year-old white patient who called the 911 emergency line with chest pain received an ECG while on transit to the hospital, and it showed an NSTEMI. So which of the antiplatelet agents listed below shouldn't be administered prior to the cath lab where he'll undergo a PCI? Would it be prasogel, aspirin, clopidogrel, or ticagrelor? I'll give you 10 seconds to choose the correct answer. The correct answer is prasogel. Now, according to the ACCOST ACCOAST trial, which was a randomized controlled trial of very high-risk patients with NSTE acute coronary syndrome who were scheduled to undergo early coronary angiography, found that a strategy of administration of prasogel at the time of randomization before angiography did not lead to a reduction in the composite primary endpoint when compared with a strategy of administration of prasogel only at the time of PCI. However, it led to an increase in bleeding complications. Now, on the basis of the Triton trial or study and the results of the Triology ACS, that is TRILOGY ACS, and they are caused ACCOAST, prasogel isn't recommended upfront as therapy for patients in NST-ACS. Now, aspirin chewable should be taken orally in the immediate treatment of chest pain suggestive of ischemia to help reduce mortality in AMI. So it doesn't fit the answer for this particular question. And clopidogrel and ticagrelor are oral antiplatelet agents which can be given prior to PCI according to the guideline recommendations, which are based on trial data. So the best option in this case would be prasogel. I would shy off from it in a patient in whom PCI is scheduled before they reach the cath lab. Let's move to the next slide. A 69-year-old male patient with a past medical history significant of COPD, hypertension, and who happens to be a smoker, abusing tobacco and used to smoke at a rate of 20 pack years, but quit 6 months ago. This fellow presents to the clinic complaining of an increasing fatigue and shortness of breath with everyday simple activities. He claims or tells you he doesn't think these symptoms have anything to do with the COPD, since he doesn't normally get this fatigued during his COPD exacerbations. Now, given his risk factors, you tend to feel heart failure could be causing this kind of symptoms. It's on your differential list. So which of the tests listed below would be the most useful to rule out or rule in heart failure? Is it BNP? Is it a chest x-ray? Would it be a 12-lead electrocardiogram? Or would it be a 2D echo with Doppler flow study? I'll give you 10 seconds to choose the correct answer. It would be the correct answer. 2D echocardiogram coupled with a Doppler flow studies is considered the single most useful diagnostic test for heart failure. BNP is a hormone synthesized and released by the heart in response to stretching and is associated with left ventricular abnormalities, including a reduced LV ejection fraction, hypertrophy, and elevated filling pressure. Now, due to the fact that BPN levels can be influenced by many other things, including age, gender, weight, its use is very limited, and it's limited to assisting in confirming the presence of heart failure. I would not consider it superior to echo. Our findings consistent with heart failure can be revealed on an X-ray, i.e. you can notice cardiomegaly, you can notice pulmonary congestion, and an ECG can also be helpful. It can show left ventricular hypertrophy, it can show you the LBB, but it should only be used for supportive purposes. I would settle for a 2D echo with Doppler flow study as my best bet in this particular case. Let's move to the next slide, which reads, you are considering antihypertensive therapy for a hypertensive 67-year-old white male whose pressure averages 159 systolic, 96 diastolic. Pay attention to the age and to the pressure. He has a heart rate of 60. Now, he suffers from arthritis of the left knee and both hips, and there was a mishap. He has a war injury which led to a right above the knee amputation, and there is no prosthetic leg. He uses crutches, at times he uses a wheelchair. This gentleman has an unsteady gait, and he tends to experience chronic constipation. His kidneys are normal, his electrolytes are fine, and you desire to start therapy for his hypertension. So which of the following medications would be the most appropriate choice in this patient? What would you initiate him on? I'll give you 10 seconds to choose from the list of carvedilol, Vasopressin, Terazosin, or amlodipine. So I would settle for valsartan. Now this patient, because of the amputation and the unstable gait, has a risk of fall. Remember, he also has osteoarthritis. That also worsens his risk of fall. Now, terazosin would clearly cause an increased risk of osteoarthritis, especially during the initiation phase. And added to this fact, it, in my opinion, cannot form the first line. I would not opt for it. It isn't considered first line given results of the all-CAT trial, ALLKAT. That trial declared it can't be first line in the management of hypertension. And amlodipine, option D, is known decrease smooth muscle contraction in the GIT. It reduces peristalsis, and it could worsen the constipation that this gentleman is experiencing chronically. So I would not opt for amlodipine. Carvedilol is a mixed alpha-1 beta blocker which can further lower pulse in this gentleman's case, and I would not want to lower the pulse below his level, which was quoted at 60. Remember, we recommend the upper 50s to lower 60s as a suitable range for heart rate, for pulse. So I would not opt for carvedilol. So that makes option A wrong as well. Now, valsartan is an ARB. It would be the safest choice in this particular gentleman's case, especially since his renal function and the electrolytes, mainly potassium, are reported to be normal. So I would not worry about hyperkalemia caused by valsartan at this stage. Now, starting at a lower dose would minimize the risk of dropping his BP too low too fast. And that would be an advisable approach to his therapy. So I would settle for valsartan as the most appropriate choice for this gentleman. So my highly esteemed viewers and listeners, that brings us to the end of part 22 of our Pharmacotherapy MCQ series. I appreciate the fact that you made time to view and to listen to this video. And if this video helped you in any way, I would like to remind you to give it a thumbs up, to like it, to share it widely with your peers and your colleagues. And above all, I would like to request you to subscribe to my YouTube channel if you haven't already done so. I would like to promise you from the bottom of my heart that the best is yet to come in this series. I would like to thank you for viewing and for listening, and I hope to interact with you in part 23 of our Pharmacotherapy MCQ series and in subsequent parts of our series. So thank you for being there for me.